Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, salam sejahtera, Om Swastiastu, Namo Buddhaya, and also good morning for Prof. Bulen Kukurcu from Spain. First of all, I apologize if I open this webinar in bahasa. Sebelumnya karena masih dalam suasana Idul Fitri, maka minal aidin wal faizin untuk seluruh pembicara, panitia, dan peserta pada hari ini. Selamat datang untuk seluruh peserta. Puji syukur kehadirat Tuhan Yang Maha Esa karena pada hari ini kita boleh berkumpul dalam acara webinar Current Update in Pcos Management. Acara ini merupakan hasil kerjasama Perfitri dan Sintesa Health. Yang kami hormati, Profesor Dr. Hendy Hendarto, SPOG Kafer, selaku Ketua Perfitri dan selaku moderator pada hari ini, Profesor Dr. Budiweko, SPOG Kafer, MPH, selaku Ketua Dewan Pakar Perfitri, dan pembicara pertama kita, and Prof. Dr. Bulen Kukurcu, PhD MBA, as Scientific Director from Catalysis Spain, and will be our second speaker today. Thank you for sharing your valuable time today with us. Maka untuk membuka acara pada hari ini, kami persilahkan kepada Prof. Hendy, selaku Ketua Perfitri, untuk memberikan sedikit kata sambutannya. Silakan, Prof.
Ya, terima kasih Pak Jati. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore semuanya, teman-teman yang hadir saat ini. Pertama-tama mari kita panjatkan budi syukur kepada Allah Subhanahu wa taala, kita diberi rahmat hidayahnya, sehat, bisa hadir pada sore yang berbahagia ini mengikuti acara webinar yang tentunya menjadi impian kita untuk meningkatkan kemampuan kita. Dan pada suasana Lebaran ini saya sampaikan selamat Idul Fitri 1443 Hijriah. Taqabbal minkum, semoga kita semua dalam limpahan rezeki dari Maha Kuasa dan juga kita mendapatkan berkah di suasana Idul Fitri ini. Tentunya pada suasana yang masih libur ini, pada ujung-ujung liburan kita masih menyempatkan untuk mengikuti suatu kajian ilmu yang tentunya bisa bermanfaat untuk kita bagaimana nanti meningkatkan kemampuan kita menangani pasien kita, dan tentu ini sangat bermanfaat. Dan saya sangat berterima kasih pada PT Sintesa Health yang tentu dengan kerja kerasnya dan jerih payahnya di masa libur ini masih menyempatkan memberikan suatu diskusi yang menarik ini. Dan juga kepada para pembicara, Prof. Budiweko, dan also our guest speaker, Profesor Bulen Kukurcu. Thank you for join the webinar, and also very appreciate your join the webinar. Dan untuk semuanya, terima kasih. Semoga acara ini menjadi bermanfaat. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Prof. Hendy untuk kata sambutannya. Ya, seperti ini diinformasikan sebelumnya bahwa pada hari ini kita akan melaksanakan webinar dengan topik utama adalah current update in Pcos management. Namun sebelum masuk ke acara utama, izinkan saya untuk membacakan sedikit tata tertib dan susunan acara pada sore hari ini. Ya, untuk yang pertama, peserta yang berada di platform Zoom tidak perlu menuliskan absensi kehadiran karena kehadiran Anda sudah otomatis tercatat di sistem. Kemudian untuk pertanyaan silahkan diisikan di kolom Q&A dengan menuliskan dengan format nama, instansi, dan pertanyaan. Lalu peserta juga akan mendapatkan sertifikat yang merupakan peserta yang memenuhi kriteria yang telah ditentukan. Lalu peserta diharapkan mengikuti seluruh rangkaian webinar. Peserta dimohon untuk tetap menjaga etika selama kegiatan ini berlangsung. Lalu sertifikat hanya akan diberikan kepada audiens yang telah terdaftar sebagai peserta. Untuk peserta yang bergabung di Zoom, di YouTube, maaf, nanti kita juga akan lampirkan link untuk absensi di YouTube. Lalu sertifikat akan dikirimkan langsung ke email Bapak Ibu dokter sekalian setelah acara ini selesai. Dan mengingatkan juga di akhir sesi akan ada 3 door prize utama. yang akan ditentukan berdasarkan 3 pertanyaan terbaik. Ya, untuk rundown-nya. Ya, untuk pembukaan dan kata sambutan tadi sudah, kita akan masuk ke sesi utama yang akan dimoderasi juga oleh Prof. Hendy. Untuk topik utama hari ini, pembicara pertama kita adalah Profesor Dr. Budi Weko, SPOG Cover MPH, dengan topik presentasinya adalah Current Update in Pcos Management in Indonesia. And then the second speaker will be Profesor Dr. Buleng Kukucu, PhD MBA, with the topic The Role of Molecular Activation Product in Patient with Pcos, yang akan dilanjutkan ke sesi diskusi dan akan ditutup dengan closing statement. Nanti akan ada door prize, penutupan, dan foto bersama. Ya, untuk mempersingkat waktu, acara ini saya serahkan kepada moderator kita, Prof. Hendy. Waktu dan tempat dipersilakan. Sebelum Prof. Hendy memulai acara, izinkan saya juga membacakan CV beliau. Profesor Dr. Hendy Hendarto, SPOG Cover. Jabatan saat ini adalah merupakan Ketua Departemen SMF Obstetri dan Ginekologi di RSUD Dr. Sutomo, Surabaya, dan merupakan Ketua HIVERI Pusat. Riwayat pendidikannya merupakan sarjana kedokteran Universitas Airlangga, melanjutkan dokter umum di universitas yang sama, termasuk spesialisnya di universitas yang sama di tahun 2003, merupakan konsultan fertilitas endokrin reproduksi, dan di tahun 2007 merupakan lulus S3 pasca sarjana program doktor ilmu kedokteran Universitas Airlangga juga. Kemudian ikut aktif di berbagai organisasi dari POGI, ID, hingga ada European Society for Human Reproduction and Embryology, termasuk Society of Reproductive Surgeon. Ya, demikian yang dapat saya sampaikan untuk CV Prof. Hendy. Sekali lagi untuk waktu dan tempat, saya persilakan kepada Prof. Hendy untuk memimpin acara pada sore hari ini. Terima kasih.
Baik, terima kasih Pak Jati. Good afternoon, everybody. Thank you for joining the free webinar with the title Current Update in PCOS Management. As we know, Polycystic ovarian syndrome is the most common endocrinopathy among reproductive age women. And the pathophysiology of the syndrome is complex, and there is no single defect in the disease. So I think it's an interesting webinar. Today, as we know, there are two speakers in the webinar, Professor Budi Weko from Universitas Indonesia and also Prof. Buleng Kukucu from Spain. The first speaker is Professor Budi Weko. Okay, Prof. Budi, we can start the lecture, please.
Yeah. Thank you very much, Prof. Hendy Hendarto. Good afternoon, everyone. And happy Eid Mubarak, Taqabbalallahu minna wa minkum. Thank you very much for Mr. Chairperson, and then also our colleagues this afternoon, ICM, and then Professor Buleng Kukucu. So I'd like to share my presentations. This is about the current management of PCOS in our country or in Indonesia. As mentioned by Prof. Hendy, that PCOS is a disease of many theories. Then we can see in the figure, the natural history of the PCOS is quite huge spectrums, because if you look the symptoms and the signs, PCOS can be studied from adolescence, and then goes to the childbearing age, menopause, and even in the postmenopausal periods. The chief complaint or symptoms of the PCOS patient can be starting from infertility or irregular menses during adolescence, or infertility, particularly in the childbearing age. People are coming to us in order to help them to have to conceive, and then during the menopause, the metabolic syndrome is the main symptoms and signs. And also diabetes mellitus, dyslipidemia or high blood pressure, or even the risk of having endometrial cancer and breast cancer after the menopausal period. We know that Pcos is an anovulatory women's that the antral stage of the follicular development are clearly abnormal. The growth of these follicles typically are arrested at the diameter between 5 to 8 millimeters, and we can see the anovulation cycles of our Pcos patients. Actually, what is the main etiology of PCOS? If we can see here, at least there are three basics pathogenesis of PCOS. Number one is insulin resistance, and number two is dysfunction of LH secretions, and number three is the low FSH level that never beyond the FSH threshold. So all the three etiologies, they can make an effect in the ovary, hyperandrogen in the ovary, and then the hyperandrogen in the ovary can disrupt the follicle developments, so that our patient will be suffered from anovulation. Women with PCOS also are under chronic inflammatory state, whether in the long term may have increasingly the risk of chronic low-grade inflammations because of upregulated of androgens, insulin, LH, FSH, ROS, inflammatory cytokines, and downregulation of adiponectin and sex hormone binding globulins. We can also see the role of anti-melanin hormone, which reduces the follicle sensitivity to FSH in human ground cells. The study from Laura Pellad, this is an in vitro study looking at the ground cells were exposed to MH with and without gonadotropin for 48 hours. The anti-melanin hormone will decrease gonadotropin-stimulated aromatase expressions, and also MH also reduce FSH receptor mRNA expression. So that's why in PCOS patients, level of MH is quite high, and then the high expression of MH will decreasing the activity of aromatase enzyme in the ground cells, and that it will induce the androgen level in the ovary, which is indirectly will suppress the level of FSH, that FSH can never beyond the threshold, so the follicular development were arrested. This is one of our study in 2014 to see how the MH level can be as a diagnostic and prognostic tools for PCOS patients. Among 142 patients, this is the group, this is PCOS group patients, and then this is non-PCOS group patients. We can see that the level of MH is 3 times higher than non-PCOS patients. This is BMI is the same. So mostly the patients are coming from overweight and obese, and then the level of LH also is higher in PCOS patients, and then no significantly different in level of estradiol and prolactin. If you look the area under the curve for MH levels, the area under the curve ROC was around 87%, and then optimal MH cutoff level was 4.45 nanogram per ml with sensitivity 76.1% and specificity 74.6%. If the patient has the level of serum index more than 4.45, they has the odds ratio to suffer from PCOS 9.35. So it means that the patient with higher level of MH, they have the risk 9.35 times higher possibility to suffer from PCOS compared to the patients with normal or low serum MH. The second thing also very interesting to see how the PCOS phenotype. If we look the Rotterdam criteria that we use to define diagnosis of PCOS, 2 out of 3 items. So the PCOS phenotype consists of 4 phenotypes. The first one is the full-blown PCOS with complete sign and symptoms, anovulation, hyperandrogen, and PCO polycystic ovary. And then number 2, 3, and 4, only 2 out of 3 items. Can be anovulation plus hyperandrogens, anovulation plus polycystic ovary, And then the last is hyperandrogen plus polycystic ovary. We can see that in the Pcos phenotype, we have one phenotype with euandrogenic. This is the phenotype number 3. And then also we have one phenotype with ovulatory. This is phenotype number 4. So actually, which one is the most severe type among the 4 Pcos phenotype? This is also one of our study in Indonesia to see how the level of AMH in the 4 groups based on Pcos related phenotype. If we can see here, the most prevalence, the highest prevalence of phenotype, Pcos phenotype in our country is the phenotype D or phenotype 4. The Pcos phenotype with euandrogenic. This is the prevalence is about 63.4%, with the level of AMH also the lowest serum AMH level of 6.1. So it means that the most beside the highest prevalence of Pcos phenotype in Indonesia is euandrogenic phenotype. Also, the level of AMH, the lowest AMH serum will be on the phenotype with euandrogenic. AMH is quite related with the level of androgen. So if the androgen is higher, it means that the level of serum AMH also will be higher. And we can see here the Pcos phenotype. This is the classical phenotype. This is full blown, and then this is hyperandrogen with ovulatory dysfunction. This is actually both A and B, the most classical phenotype with the most severe phenotype of Pcos, with high level of insulin resistance, glucose intolerance, and also high level of having diabetes risk. And this is against low-grade inflammations in Pcos patients. And then the last, this is ovulatory dysfunction with euandrogenic. This is the lowest, the less severe phenotype in Pcos. Again, we can see the scheme outlining pathophysiology of Pcos, related health burdens and target in the future. So the patient with obesity, insulin resistant and hyperandrogenic state, they will suffering from low-grade inflammatory state. This is the increasing the risk of metabolic syndrome, hypertension, dyslipidemia, and then the future, of course, type 2 diabetes mellitus and cardiovascular disease. So that's why the spectrum of Pcos is quite huge, not only infertility and also abnormal uterine bleeding, but also the metabolic syndrome and endometrial cancers is the risk factor of our Pcos patients in the future. This is one of also our study in 2020, trying to see how the correlation of AMH level with metabolic syndrome event in Pcos patient in the cross-sectional design. Yeah, among the 4 phenotype of Pcos patients, that is where we can see here that no significantly different in terms of age and also in terms of BMI, the waist circumference, yeah. And then this is where we can see that the fasting blood glucose, and then the diabetes mellitus, the prevalence is quite high in phenotype 1 and also phenotype 3, and AMH level the highest in the phenotype 1. This is the more classical phenotype of Pcos. And this is among the 4 phenotype. We have almost the same distribution of the 4 phenotype. And the level of AMH is quite high in the phenotype 1. Now this is a metabolic syndrome. In the phenotype 1 is the highest, 36.1%. And then followed by also in the phenotype 4. Actually, this is quite rare. This is in the euandrogenic patient. In the euandrogenic Pcos phenotype, also they have around 17.8% the patients suffering from metabolic syndrome. Even it's not significantly different. They're significantly different only in the Pcos and the phenotype 1. So this figure, this table explaining how the Pcos phenotype in Indonesia currently also they have increasing risk of metabolic syndrome, particularly in the phenotype 1. And then the next is a study by Stefano Palomba trying to see how the obstetric risk factors correlated with different Pcos phenotype. This focus on early trophoblast invasion and presentations. That implantation site vessels will be diverged significantly among Pcos phenotype. The overall incidence, that microscopic placental lesions, was significantly higher in the full-blown of Pcos phenotype. So that's why the most severe Pcos phenotype, they also will have the highest risk in obstetric. So no wonder if we have our Pcos patient getting pregnant, they has higher risk to suffering from severe preeclampsia or even gestational diabetes mellitus. And to see also the outcome, the risk of the Pcos patient in cardiovascular risk, we can see here, this is the Pcos, the criteria. This is euandrogenic Pcos, this is ovulatory Pcos, this is classical Pcos. In the classical Pcos, the phenotype B and phenotype A, androgen were elevated. Then we can see the cardiovascular and metabolic risk also increase. This is the in the classical phenotype. Then euandrogenic is quite small, increasing the cardiovascular and metabolic risk. So that's why we have to be very careful in managing the Pcos patient with the full-blown phenotype, phenotype 1 or phenotype 2 with increasing the level of hyperandrogens. Our study also trying to see how the correlation between serum AMH and insulin resistance among Pcos phenotype. This is we are trying to answer whether the serum AMH level, they have indirect relationship with the incidence of insulin resistance in Pcos, particularly for Indonesian patients. This is again among 4 phenotype of Pcos. The level of AMH is quite high in phenotype 1 and 2. And also, this is LA to FHH ratio and HOMA insulin resistance, the highest in the type 1 and also the type 2. So higher AMH level will be also higher HOMA insulin resistant. If you look this one, also the fasting insulin, the phenotype 1 and phenotype 2 is the highest one. This is compared with the fasting glucose. Yeah. You can see that the serum AMH that has indirect relationship with the HOMA insulin resistance level. So that's why in the next study, we are trying to see how the treatment of insulin sensitizer, whether metformin or bioactive fraction of cinnamon, on serum AMH in women having Pcos. This is a double-blind and randomized control trial. We are going to see how the effect of the metformin after 6 months of the treatment. Number one is toward AMH level. This is among 20 patients. We can observe the changing of AMH after metformin treatment. And then among 20 patients, the 5 patients getting pregnant spontaneously after 6 month treatment of metformin. And we can see that is the changes of AMH before and after treatment of metformin. They're significantly different. The higher metformin, and then after 6 months, they're getting lower, and then the patient getting normally spontaneously ovulation. And then the second group for the bioactive fraction of metformin, only 2 among 18 patients after 6 month treatment of bioactive fraction of cinnamon, the patient getting pregnant spontaneously. Also, the first patient, the second patient, they have the AMH level decline after 6 month treatment of bioactive fraction of cinnamon. So I think this is very interesting to see how the relationship between serum AMH with insulin resistance, and also the relationship and also the effect of insulin sensitizer treatment toward declining of serum AMH in our patients. This is also randomized double-blind and non-inferiority study trying to see the bioactive fraction of cinnamon compared to metformin. This is after 6 months of treatment. We can see the effect of the bioactive fraction of cinnamon toward the stromal and ratio in the ovarian, to see how the effect of the insulin sensitizer will decreasing the level of androgen by stromal area index of decreasing the stroma ovarian stroma with area index. And this is toward BMI and waist circumference. There is no significant difference. And we can see both of the bioactive fraction and metformin treatment, they increasing the regular menstrual regulatory rate among the both of the group. This is the before the treatment. This is regular menstruation only 1.6 until 3.3%, and after the treatment, the regular menstruation increasing until 14% until 16%. Even if you use the per protocol up to 50%, the menstrual pattern was becoming normal or regular after the treatment of insulin sensitizer. This is one of the study in Pcos patient in Indonesia in our group also. We can see here trying to see how the AMH level can be used as the predictor of response in Pcos if we treat our patient with CC. This is of course the ovulation status. This successful ovulation after CC. And then this is unsuccessful ovulation. We can see that level of AMH is quite higher in the group with unsuccessful ovulation. And the cutoff point is 8.58 nanograms. So if we have patient with level of serum AMH higher than 8.5 nanogram per milliliter, so I think they have 80% to suffering from CC resistance. So that's why we should be very careful. We should be pay more attention for the Pcos patient with high level of serum AMH. The last study in our group also trying to see the genetic variants of LH in the Pcos patients correlated with the ovarian response. So we are trying to see whether the some group of Pcos patients they have beta LH variants. Because we can see some even rare Pcos patient they need some LH supplementations during the stimulation. So that's why we divide the Pcos patient into two groups. Number one is hyporesponse. Hyporesponse means that the follicles, the mature site less than 4. Less than 9, so less than 9, we retrieve oocyte less than 9, and then the normal or hyperresponse is over 9 mature oocyte during oocyte retrieval. So we divide into two groups. Then there is no significantly different. Actually, in the term of obesity and also there's no significant difference in term of AMH level. This one is total gonadotropin. Also, there's no significantly different. And this is oocyte, mature oocyte in the hyperresponse 6. In the normal and hyperresponse, at least they have 12 oocytes. And then free androgen index with ovarian response, there is no significantly different. Both of group are androgenic because this free androgen index is not significantly different between both of group. And we are trying to see whether there is any mutation in the 2-point mutations. Number one in RS 1800-447, and then number two in RS 34-34-98-26. And then we are trying to see in the both of group the hyperresponse and normal or hyperresponse. This genotype AA becoming AG, AT and AG. And this is genotype AA becoming this is AT, AG, and TT. Unfortunately, we still did not find any significantly different between both of groups. This is the genotype. This is the wild type. This is the mutant type. There is no significant difference between both of group in the variant polymorphism. RS 1800-447 and also RS 34-34-98-26. There is no significant difference. This one is the wild type AA and also heterozygote AG or AT. This is also in wild type AA or heterozygote AG, AT or homozygote TT. This is when the both of the hyperrespond and the normal hyperresponder. So unfortunately, we still did not find any significant difference in terms of beta LH variant polymorphism in Pcos patients. Even also, we are trying to see to make a sequencing of the LH, trying to see how the variants of beta LH. This is the for the RS 1800 447. This is for RS 84, 84, 98, and 26. Even we find some new mutation in our population, but unfortunately, not significantly different between two groups. Yeah, actually, we are trying to see whether we can detect the PCOS patient who will be suffered from hyperresponse, so we can start the LH supplementation earlier during ovulation stimulation in IVF. And I think this is the last, the international evidence guidelines. We can see how the treatment, pharmacological treatment of non-infertility indications. We can see the second line pharmacologist, most likely this is insulin sensitizer, anti-androgen, or insulin sensitizer plus lifestyle. They are particularly pay more attention for patients with BMI more than 55, or even the BMI with this is the high risk to suffering from metabolic syndrome, and also high risk to suffering from CC resistant. They recommend to add some insulin sensitizer. So in the infertility patient also, we can see that the use of insulin sensitizer, even in the first line, but metformin, they become in the fourth choice, the third choice, yeah, after letrozole CC. If we find any CC resistance or CC failure, yeah, CC resistant, we can add metformin, particularly in the obese patients. And also, there's a interesting possible role of vitamin D supplementations. If you look, our PCOS patient, most of them are deficiency of vitamin D. Then the low level of vitamin D also decreasing the insulin secretion and make an effect on suppressing on insulin resistant, insulin receptor. So that's why inducing the insulin resistant that can induce PCOS. And then some study evidence also, they had correlate the level of the evidence of insulin resistance with the deficiency of vitamin D. So that's why many evidence recommend supplementation of vitamin D starting from at least 4,000 IU per day until 50,000 IU per week. It means around 6,000 IU per day. We are decreasing the total testosterone and decreasing the free androgen index, and also decreasing high sensitive CRP. It will decreasing the risk of our patient to suffering from metabolic syndrome. And the last, I think, if we have our PCOS patients with the very high level of serum AMH, it will have a correlation with the CC resistant and metabolic syndrome. So that's why very important for improving the lifestyle, and also trying to see the treatment with the insulin sensitizer and also vitamin D that will also decreasing the serum AMH and improving ovulation, and also will decrease the risk of metabolic syndrome. It's quite important to see. It's quite interesting to see how indirect relationship between serum AMH and the insulin resistance itself. So as take-home messages, number one, the serum AMH can be used as a diagnostic and also the prognostic biomarker of PCOS. The number two, the prediction of obstetric risk and metabolic syndrome and PCOS are correlated with serum AMH, and the relationship between insulin resistance and serum AMH should be investigated. And serum AMH can be used for prediction of CC resistance in PCOS. Then the correlation between variant beta LH in PCOS with ovarian response should be elucidated further. And vitamin D supplementation has potential role in management of PCOS patients. Thank you very much for your kind attention.
Thank you, Prof. Budi Weweko. This interesting lecture. Yeah, especially in your study about the PCOS phenotype in Indonesian population. I think it's interesting. And there are a couple of questions in Q&A box. You can prepare the answer for this. So I continue for the second speaker, Professor Bulan Kukucu from Spain. He is a scientist specialized in the area of biology, and he works as an advisor and scientific director in the scientific department of catalysis. Professor Bulan, it's time for you.
Thank you. Thank you so much. First of all, I would like to thanks for inviting me to this interesting organization, and also I would like to congratulate Professor Budi and his team in very impressive studies. As a scientist and as a scientific manager of catalysis company, as a biologist, I would like to transmit some information related to our product, which is one of the products that physicians use in clinical practices against polycystic ovarian syndrome. So first of all, I would like to share the screen. I think you can see the presentation right now. And first of all, I would like to briefly talk about our company. Our company is a Spanish company established 40 years back. As a part of European Union, we produce different health products for different lines. And we have a know-how, with this know-how, with this technology that exclusively catalysis company has, we increase therapeutical mechanisms or therapeutical power of each of the compounds that we use in our products. Instead of looking for new compounds and developing these for different diseases, what we do is we work with natural-based compounds and we potentiate them with our technology. And we increase their antioxidant capacities and specific activities. We can summarize this technology in this with these pictures. We have in our factory reactors. In this reactors, we produce time and intensity depending electrical field to each of the chemical factors of each of these natural compounds. Without changing their chemical structure, we potentiate their internal energy and their activities. We can give an example of salicylic acid as a powerful antioxidant besides with other activities. This antioxidant capacity, as you can see in this picture, how it's increasing, and when it reaches the point 1 and 5, it has the maximum antioxidant capacity. All compounds that we use in our products are potentiated. We increase their efficiency. That's why it's giving this clinical results immediately. And also one of the characteristics of our products, they are multimolecular products. That means that the problems are because of the different factors and accumulation of these factors during the long times, and the solution that our company gives to attack to those problems by different mechanisms. That's why these two point is part of the molecular activation technology. One is increased biological activities, and second, multimolecular solution. So that's why our products give always benefits in the clinical trials that we can share with you in publications. And we succeed these biological results, clinical results with less concentration of the compounds. We don't need to charge the compound, the organisms with the excess of the compounds. And thanks to this low dose, low concentration, and more efficiency results, we have no side effects. That means that when you use our products, you're not going to damage any other organs, any other system. And also, you see the results normally in a very short time. And these compounds in our products that we present as multimolecular, they have a very important chemical synergy between them. That chemical synergy also protects these compounds and increase even more their biological indications. But the most important creates an important links with other therapies. So that products that we will talk today, Diasulin or DML synonym name, it is also a powerful adjuvant to other therapies and other products that we use in clinical practices. So Diasulin, or the other name, synonym name is DML. You will see also in the clinical trials this name, DML, but in Indonesia it's registered as Diasulin, but these are exactly the same products, generally we use for metabolic disorders. But today, especially, we will share the information related with the insulin-resistant diseases, and one of these most important is polycystic ovary syndrome. And when we check the insulin resistance issue, that is more normally in the papers, you will find that this insulin resistance is associated with chronic low-grade inflammation, and it's related with promotion of hypertension, oxidative stress, endothelial dysfunction, type 2 diabetes, and pro-inflammatory cytokines that which are involved in this insulin resistance. We can see is a typical TNF alpha, interleukin 1, beta IL-6, leptin, and all this relationship with the different pathologies that is increases lipolysis, impairs insulin signaling, so on. So when we check the conventional pathophysiology of diabetics, it's related with the kidney disease, and this is closely associated with the renal hemodynamic changes, ischemia, glucose metabolism abnormalities, oxidative stress, inflammatory response, and overactivated renin-angiotensin-aldosterone, which is contributes to glomerular hypertension and sclerosis, tubular interstitial fibrosis, tubular atrophy, and mesangial cell expansion. And when we study polycystic ovarian syndrome, what is the most common endocrine metabolic disorders related to perimenopausal women, and is defined the combination of symptoms of androgen excess, ovarian dysfunction, and so on. So that is directly related with abdominal adiposity, insulin resistance, obesity, metabolic disorders, and cardiovascular risk factors. There's orchestration of different factors. It's not the 1 day, 2 days problem. It is the accumulation of these factors in many years and many times. So when we have in this picture, polycystic ovarian syndrome summarization, which is genetic predisposition to access ovarian androgen secretion. When we check the cycle, we see the pituitary gland and liver, and between these, the increased testosterone levels, increased insulin resistance and hyperinsulinemia, and luteinizing hormone levels are high. And together with this, we have anovulation and genetic and dietary factors influence, so on. Beside of this, hirsutism. And when we said that we have to also use a multimolecular product which gives several mechanisms of action for normalizing the different problems related with polycystic ovarian syndrome. Diasulin is an important product because, as you can see, is the orchestration of different activities. We have in the product L-carnitine, which is important to convert the fat into the energy, helps to control glycemia. We have arginine. It's also the fat mobilizer, ornithine, which is stimulates the insulin secretion. the increased arginine levels. Glycine is important for the liberation of glucagon. Calcium pertotonate is also the converter, the fats, sugars into the energy. We have powerful antioxidants, which is especially important for the resistance to insulin. We have folic acid, vitamin B12, C, B6, which are important elements for the recuperation of the defense mechanism. We have zinc as a powerful biocatalyzer, potassium, magnesium, and alfalfa extracts, which is reduces the absorption of glucose. And we have blueberry extract, which is important element for stimulating the microcirculation. And thanks to all these main elements of the product, we see the mechanism of action of Diasulin in 4 levels. In fact, in 5 levels. In pancreatic level, which is a stimulation of the production of insulin thanks to arginine zinc sulfate. We have important activity in reduction of assimilation, absorption of carbohydrates and sugar, like till 30% in the intestinal tract. We have activity as a powerful antioxidant in the cells, and that is especially important the use of insulin and the resistance to insulin, or the sensibility to insulin. And in the kidney level, we have activities also. We have amino acids, which are the substitution of the escaped nutritional elements in kidney because of metabolic disorder. And also we have important liver protection activity together with Diasulin. So as you can see in the different systems and different level of activity giving one product. We have, of course, with Diasulin or Diamel, several clinical activities in the last years, but it is one of the historical product of catalysis. We have many clinical experiences, publications, and experiences with this product. In this study, I will share with the one which they did in Havana, in Cuba. In this study, they had 37 patients with polycystic ovary syndrome problem. It was a study with a triple blind clinical trial, and in this trial they found a significant decrease in the HOMA-IR from the initial value at 6 months was with the group of DML. The insulin sensitivity improved considerably in the DML or Diasulin group. The rate of menstrual recovery was higher in the group of treatment, and the pregnancy rate was also high, and the decrease of testosterone in 3 months happened with the Diasulin group comparing the control group, and luteinizing hormone also decreased in the same group, treatment group, in 6 months. So the resistance to insulin and the improvement of the sensitivity regulates, and also that the testosterone levels was regulated. That is the table that summarizes these results. This is the insulin resistance index in 3 months and 6 months time. This is Diamel or Diasulin group and placebo, and this is insulin sensitivity index. As you can see, this important comparison results, and also the regulation of the testosterone in combination and comparison with placebo in starting point 3 months and 6 months time. And here also the summary of the study shows us also not only in this, but also a regulation in and triglycerides, cholesterol, and also the glucose levels in 4 weeks, 12 weeks, and 24 weeks, comparing to placebo. And that means that Diasulin has several activity, as we can see here, and that gives us controlled luteinizing hormone levels, controlled testosterone levels, reduced insulin resistance, and controlled insulin secretion, and that gives a regular ovulation and also regulation in the insulin levels, and thanks to hepatoprotector activity, and finally reduction of polycystic ovary problem, and then the regulation of oversecretion of androgen, and of course reduction of hirsutism. Beside of this, I would like to mention also our product Use It, which is known the last months because of COVID-19 that we use in Indonesia. So the physicians use in COVID-19 treatments management, but this product also known a powerful hepatoprotector together with immunomodulation effect. It contains different molecules. It's a multimolecular product again. It has immunomodulator, anti-anemic, antioxidant, biocatalytic effect, antiviral effect, but the main compound is activated glycyrrhizin. Like Diasulin elements, all these molecules are activated, potentiated, increase their activities. But also we have to mention glycyrrhizin as the main compound. It's related with its relationship with high group mobility box 1 protein. This protein I would like to share here. This extra, the other name, synonym is amphoterine. Extracellular amphoterine is implicated in many diseases, like here allergies, like in COVID-19 issues, creating activation of pro-inflammatory cytokines. It's, as we can see here, this extracellular amphoterine secreted by many different cells after a necrosis zone. Normally this intracellular amphoterine is very important because it participates in many activities, like interacts with nucleosomes, transcription factor histones, and it's binds the DNA for the binding with other proteins. But extracellular amphoterine, if it's not neutralized, then create injuries and is causing many diseases related with the inflammation. As we can see here, cystic fibrosis, obesity, polycystic ovary syndrome, hyperinsulinemia, and many different inflammation related with these metabolic disorders. Amphoterine is the responsible, like in respiratory system problems, or again is because of COVID-19. That's why this scientist here, because of its several activity of glycyrrhizin, recommended the use of this product in the treatments of COVID-19, and they did, and we did also after clinical trials and publications we can share with you. We used in the management of COVID-19, and this activated glycyrrhizin in our product also give us important clinical results and publications we can share with you. Thanks to molecules in glycyrrhizin, it's a powerful hepatoprotector that we can use instead of hepatitis, but also we can use in the treatment of non-alcoholic fatty liver diseases, in all related with hepatitis C related decompensated cirrhosis, that which we have a important publication from British Medical Journal. Also other studies, how is a powerful adjuvant in the protection of liver together with ribavirin and interferon, and the last studies related with COVID-19. So That was the information I wanted to transmit you. Now I'm ready for your questions and answers. Thank you very much for your attention. Thank you.
Thank you, Professor Bulan, for the interesting lecture about the new treatment for PCOS thing. Okay, there are a couple of questions. First of all, to Professor Budi Weko. You can answer it in English or in Indonesia. Karena banyak sekali pertanyaannya. Silakan, Prof. Budi. Dari atas mungkin.
Ya, baik. Ya, thank you, Prof. Hendy. Allow me to answer in bahasa, I think. Ya, yang pertama mengenai pertanyaan tentang PCOS, ya, kemudian treatment dengan bioactive fraction of cinnamon, folic acid, coenzyme Q10, kaitannya dengan keguguran. Ya, memang salah satu masalah dari PCOS ini adalah kualitas sel telur yang tidak terlalu baik. Ya, kita tahu bahwa pada kondisi hiperandrogen, pada kondisi chronic low grade inflammation, itu adalah salah satu faktor yang menyebabkan kualitas sel telur pada pasien PCOS itu tidak terlalu baik walaupun telurnya banyak. Akibatnya tentu menyebabkan tingginya faktor risiko untuk terjadi miscarriage. Ya, tadi salah satu studinya Palomba menyatakan bahwa masalah utama pada PCOS itu juga masalah presentasi, ya, invasi trofoblast ke dalam DC2. Itu menjadi masalah. Oleh karena itu untuk mengatasi PCOS ini kata kuncinya adalah harus sabar dan konsisten, ya. Perbaiki lifestyle, kemudian multiple micronutrient supplementation is quite important for us, ya, to see how the improvement of oocyte quality is very important. Pertanyaan kedua, the second questions, resting follicle, mungkin might be what they means is from Dr. Adia, ya. Dr. Adia means is the follicular persistence. Somehow kadang-kadang memang kita bisa menemukan adanya follicular persistence pada saat menstruasi. Itu menandakan bahwa proses luteolisis dari siklus haid sebelumnya tidak berjalan dengan sempurna. Oleh karena itu pada kondisi demikian biasanya kita tidak ingin melanjutkan dengan stimulasi atau induksi ovulasi. Karena ada proses luteolisis yang tidak sempurna. Umumnya kalau kita lakukan pemeriksaan progesteron, kadar progesteronnya masih tinggi. Sehingga kita harus menunda untuk melakukan induksi ovulasi atau stimulasi ovarium. Jadi kita bisa tunda pada satu siklus atau beberapa siklus untuk melihat, meyakinkan bahwa tidak ada lagi follicle persistence atau proses luteolisisnya sudah kembali sempurna. Berikutnya fenotipe, ya, 4 PCOS. Ini memang menarik, ya. Salah satu fenotipe dari PCOS itu adalah pasiennya tetap ovulasi. Ya, tetapi dia mengalami ada polycystic ovary dan ada hyperandrogen, ya. Walaupun ini sangat-sangat jarang, tetapi ada spektrum fenotipe seperti ini. Treatmentnya seperti apa? Tentu treatmentnya kita harus tegakkan diagnosis dengan baik, ya. Kemudian induksi ovulasi somehow tidak diperlukan. Ya, tapi memang betul sekali bahwa pemberian insulin sensitizer mungkin ini sangat penting karena dia ada hiperandrogen, ya, kemudian ada resistensi insulin, ya. Umumnya hiperandrogen itu berkorelasi dengan resistensi insulin. Aromatase inhibitor umumnya itu direkomendasikan pada pasien PCOS yang memang mengalami gangguan ovulasi, ya, seperti itu. Walaupun ini, ya, itu saya kira. Kemudian pada wanita yang belum menikah, treatment PCOS itu, ya, sangat mudah, ya. Buat saja pasiennya itu menstruasi teratur dengan memberikan pil kontrasepsi kombinasi. Karena pil kontrasepsi kombinasi itu satu, dia mengandung etilenestradiol. Etilenestradiol ini akan meningkatkan sintesis seks hormon binding globulin sehingga akan menangkap free androgen index, dan juga pilihlah pil kontrasepsi kombinasi yang preparat progesteronnya memiliki sifat anti androgenik, ya, sehingga itu akan memperbaiki performance metabolik dan juga performance reproduksi, ya, nantinya bila pasien sudah menikah, begitu, ya. Metformin memang kadang-kadang dia menimbulkan gejala intestin yang berat. Karena itu ada metformin extended release yang bisa 500 mg atau 1000 atau 450 atau 1000, atau mengkonsumsi metformin di tengah-tengah makan, atau ada alternatif yang lain, yaitu ada bioactive fraction dari cinnamon. Studi kita membuktikan efek GI tract-nya bioactive fraction ini cinnamon ini sangat-sangat rendah. Pcos phenotype tipe 1 ya.
Kita
Boleh Prof. Hendy.
ke Prof. Bulan dulu
Sebentar
ya.
itu dulu Prof. Hendy.
Okay. Thank you. Now the question from Prof. Bulan, the question from Dr. Prianto from Bina Medica Hospital Bintaro to Professor Dr. Bulan. What are the hyperinflammation activities happen in PCOS patient, and how do these hyperinflammation activities cause higher AMH in this patient?
Yes, thank you very much for the question. As I mentioned, we have several activities of Diasulin that are acting in different systems, in different organs. But one of the important cause for the inflammation is high mobility glucose 1 protein that is intracellular. It is because of the death of the cells. It's in the area, and that creates an important multiple inflammation that affects also to this pathology, hyperinflammation. And it is also related with AMH. We have as a result of the SHBG levels are increased, reduced, which is sex hormone binding globulin, and that is one of the causes of hirsutism. And together, the multiple action of Diasulin, it's also normalize these globulin levels together with lutein hormone levels. So finally, it's the orchestration of different results, as I can say here.
Thank you, Prof. Bulan. The second question for you from Dr. Anita Rohmah. What's the advantages or disadvantages about the comparison Diasulin compared with metformin?
Well, actually, normally we don't like to make the comparisons. Of course, as Dr. Budi also in his studies mentioned, natural-based compounds like cinnamon, and also like the compounds that brings DML has several activities, not one target results. Probably that could be the comparison. When we talk about the natural molecules, we have more than one activities. So there's the orchestration of different activities in normalization of different problems. So that's why directly I cannot compare. But if the physician use metformin, and DML perfectly could be adjuvant to this the metformin use also. So that can be combinatory use.
Okay, thank you, Professor Bulan. Now we move to Professor Iko. There's also a couple of questions to you, Professor Iko.
Ya, saya coba melanjutkan nih pertanyaan-pertanyaannya. Ya, jadi kalau berikutnya ini pertanyaan sebentar. Pertama kemudian ini pertanyaan dari mengenai guideline HIVERI ya. Saya kira guideline HIVERI sudah ada ya untuk PCOS ya, dan juga sudah ada guideline HIVERI untuk penanganan infertilitas ya. Jadi silakan teman-teman bisa mendownload itu. Dua-duanya ada, treatmentnya seperti apa, diagnosis seperti apa. Kemudian apakah penanaman PCOS sudah tepat? Ya memang Polycystic Ovarian Syndrome. Karena yang kita namakan ya sindrom itu kumpulan gejala dari gambaran klinis ya si ovarian polycystic ya. Dia bisa spektrumnya begitu luas karena makanya ada kata-kata sindrom di sana. Kemudian untuk Dokter Inu saya kira tidak ada ini maksudnya mungkin earlier detection kali ya, deteksi dini. Kalau dari studi kita, deteksi dini itu adalah ya tadi salah satu yang bisa digunakan adalah AMH serum. Ya, kalau hematokrit di atas 4,45 nanogram per mililiter, salah satu radar kita lah bahwa ini kemungkinan akan terjadi gangguan ovulasi. Apalagi kalau pasien-pasiennya ada ya, risk factor yang lain ya, obesity, ya, kemudian ada genetik dari diabetes mellitus, itu yang kira-kira kita bisa meningkatkan kewaspadaan. Kemudian untuk reseptor endometrium, memang pada pasien-pasien gangguan ovulasi, seringkali endometriumnya tentu dia karena terekspos dari anopos estrogen, dia menjadi sangat tidak reseptif. Oleh karena itu, selain kita fokus fokus memperbaiki ovulasi, tentunya reseptor endometrium juga menjadi sangat penting ya. Biasanya kita bisa berikan progesteron siklik ya, bisa sampai 3 sampai 6 siklus ya, bisa melihat sampai endometriumnya itu triple line, kemudian subendometrial blood flow-nya bagus. Nah, itu baru kita berani merekomendasikan pasien untuk hamil spontan ataupun yang lainnya. Kemudian dosis insulin sensitizer. Insulin sensitizer sendiri di kita kan ada golongan biguanid, metformin, dan sekarang ada bioactive fraction dari cinnamon. Metformin biasanya starting dose-nya kita idealnya tuh 1.500 ya, tapi kadang-kadang mual biasanya kita mulai dengan 1.000, ataupun nilasin kita mulai 100 ya, atau 2 kali 100 ya. Kemudian bagaimana mengetahui jenis-jenis Pcos yang memerlukan terapi tambahan? Sebenarnya semua jenis spektrum Pcos itu memerlukan multiple micronutrient ya, supplementation ya, seperti tadi disampaikan oleh Prof. Kucu ya, Diasulin itu kita perlu ada folic acid, kita perlu zinc ya, kita memerlukan vitamin D dan yang lain-lain ya, sangat banyak antioksidan, yaitu merupakan terapi adjuvan juga sangat penting bagi pasien kita. Kemudian tetap treatmentnya tetap kita ikuti guideline. Saya jangan lupa kita punya International Evidence Guideline 2018 baik untuk pasien infertilitas maupun untuk pasien non infertilitas. Kita juga punya guidelines dari Hiveri tentang PCOS, silakan ikuti itu. Ya, lihat keluhannya apa, apakah infertilitas ataupun non infertilitas. Jadi kalau infertilitas tetap lini pertamanya adalah induksi ovulasi. Sekarang dengan aromatase inhibitor atau letrozol, ya kemudian boleh juga boleh juga sisi, boleh sisi plus metformin. Ya, metformin alone dia memberikan efek tapi lebih lama dibandingkan dengan sisi plus metformin ataupun letrozol plus metformin. Lini kedua baru dilakukan dengan gonadotropin atau drilling, dan lini ketiga IVF. Kadang-kadang kita bisa mendorong gonadotropin itu sebagai lini pertama kalau kita melihatnya pasien ini berisiko untuk mengalami sisi resisten, seperti pasien yang obes, pasien LH-nya sangat tinggi, ataupun yang AMH-nya sangat tinggi. Satu lagi saya sampaikan sebelum saya ini ke Prof. Hendi dulu ya, adalah bagaimana perbandingan antara metformin dengan inlasin ataupun metformin plus inlasin atau bioactive fraction cinnamon ya. Ada satu studi kita lagi, ini tadi saya belum menyampaikan, bagaimana metformin dan cinnamon itu keduanya bisa memperbaiki HOMA IR ya, menurunkan HOMA IR. Hanya pada saat kita menggunakan metformin, begitu treatmentnya di stop, itu reboundnya lebih cepat ya, HOMA IR-nya naik lagi dibandingkan dengan kelompok cinnamon. Oleh karena itu, kemudian ada kelompok yang ketiga itu kombinasi metformin dan cinnamon. Nah, itu lebih baik ya, dia bisa menurunkan HOMA IR dan mencegah terjadinya rebound yang begitu cepat setelah terapinya di stop. Saya kira demikian dulu, Prof. Hendi. Terima kasih.
Yeah, thank you, Prof. Budi. Now the question for Prof. Bulan. Prof. Bulan, as we know, PCOS is a chronic disease with the result of chronic anovulation and also infertility. And now we use molecular activation technology with the change the molecular structure of the compound. The question is, what is the side effect if we use molecular activation technology for long-term treatment?
same structure, but with more energy. That energy increases biological activities of the compounds. They amplify their activities. That's why I was giving salicylic acid example. This is antipyretic, anti-inflammatory, but it is antioxidant also, this compound, and we use for ages. And this compound increase visually its capacity. We increase the polarity of the molecules, we increase their capacity of transport of electrons, but we reduce also the side effects, possible side effects, because we don't need to use high concentrations as a natural molecule. Very low concentration will give us better clinical results.
Okay, thank you. The next question about to Professor Bulan. How about the dose of Diasulin? We must pay attention about the body weight of the patient.
Well, actually, we have regular use of the product three times per day, independently the body weight of the patient. As we have an important march thanks to molecular activation, we don't use high concentration. So this regular 3 times per day of use of the product will give us all these clinical results which we decide at the beginning.
Thank you. Okay, back again to Professor Budi. Still ada question?
Ya, terima kasih Prof. Hendi. Ya, beberapa pertanyaan terkait dengan penanganan PCOS pada pasien-pasien yang kadar AMH serum ini sangat tinggi. Ya, ini memang kita harus sangat berhati-hati ya. Studi kami membuktikan kadar AMH yang sangat tinggi itu berkorelasi dengan tingginya androgen dan juga tingginya HOMA-IR. Jadi pada kasus-kasus demikian pilihannya ada 2 ya. Pada kami biasa melakukan treatment dengan selain perbaiki lifestyle ya, juga dengan exercise, kita memberikan insulin sensitizer. Ya, studi membuktikan bahwa insulin sensitizer itu 8 minggu atau 3 bulan itu bisa menurunkan AMH. AMH-nya menurun, pasien bisa ovulasi spontan atau kemudian baru dilakukan induksi ovulasi. Ya, studi kita bahkan membuktikan 6 bulan itu pasien bisa ovulasi spontan. Atau sejak awal dikombinasikan antara insulin sensitizer dan agent induksi ovulasi ya, CC plus metformin ataupun letrozole plus metformin. Studi sudah cukup banyak ya yang menghasilkan yang evidence-nya cukup baik ya, walaupun memang sampai saat ini guidelines itu masih menempatkan insulin sensitizer itu di pilihan ketiga pada lini pertama ya, tapi itu kita bisa dorong. Atau yang kedua, kasus-kasus yang demikian, kalau kita yang kombinaan, maka kita boleh melakukan induksi ovulasi dengan menggunakan preparat gonadotropin, ya dosis rendah kronik, ya bisa disuntik selama 1 minggu atau bahkan 2 minggu, tentu dengan close observation dengan ultrasonografi yang baik seperti itu. Ya, kemudian ada satu pertanyaan lagi tentang treatment dengan antagonis AMH ya. Memang sekarang orang sudah mulai menulis ya adanya antagonis AMH. Antagonis AMH ini salah satu obat yang dikembangkan ya dari analog AMH untuk menekan ya tingginya AMH pada pasien-pasien PCOS ya. Ini masih dalam tahapan research dan itu bisa ditemukan sehingga akan membantu pasien dengan PCOS. Kemudian untuk menunda kehamilan, pilihan apa yang paling tepat? Yang paling baik adalah kontrasepsi tentu, progestin, anti-androgen kuat. Ya. Ini tentu akan memperbaiki ya, evidence sudah sangat banyak. Ya, OCP itu bisa memperbaiki performance metabolik dan juga performance reproduksi ya setelah OCP-nya atau PCOS-nya di stop ya. Kemudian tentang sel line dari pasien PCOS, saya kira kita bisa menggunakan apa saja ya. Kita tidak menggunakan sel line khusus untuk PCOS. Biasanya kami melakukannya dengan sel granulosa yang dikultur secara in vitro. Kita bandingkan sel granulosa dari pasien normal dibandingkan dengan sel granulosa dari pasien-pasien PCOS ya. Kemudian kita bisa melihat berbagai macam ekspresi ataupun juga bila diintervensi dengan berbagai macam pilihan treatment. Saya kira itu Prof. Hendy dari pertanyaan-pertanyaan yang ada yang sempat saya baca di layar. Terima kasih.
Okay, thank you, Prof. Budi. The question to Professor Bulan about the use of Diasulin in Pco patient. Is we use the Diasulin as a single treatment or combined with another insulin sensitization agent?
Depending on the disorder, the physician decides in combination or alone. The studies we have, normally it's monotherapeutical, the long-term use of Diasulin, but also like metformin, and you can combine perfectly and you can potentiate as a powerful adjuvant Diasulin the results, clinical results.
Okay. Maybe Prof. Iko would have a question to Professor Bulan.
Ya, sebelum itu mungkin ada satu pertanyaan yang terkait dengan depresi ya. Memang Pcos itu salah satu dari keluhan atau gejala dari Pcos adalah adanya depresi atau paranoid ya pasien-pasien Pcos karena itu terkait dengan aksis dari hipotalamus dan pituitary ya. Kemudian itu studi membuktikan itu. Kemudian dibalik apakah depresi bisa meningkatkan menjadi faktor risiko terjadinya Pcos. Saya kira yang sudah ada pasien-pasien dengan anxiety tinggi itu merupakan faktor risiko untuk terjadinya gangguan ovulasi ya, tetapi tidak pada spektrum Pcos. Begitu. Ya. Kemudian my short question to Professor Bulan, it's really interesting the role of Diasulin for improving insulin resistance. So I'm quite interested to see how the effect of Diasulin toward of serum AMH instead of coma ER that you present on your presentation.
Yes, definitely. I mean, as I mentioned, we have different activities of Diasulin thanks to this multimolecular environment. We talk about the vitamins complex, zinc in there, magnesium, all together with amino acids, and that compounds, this combination works a powerful antioxidants. Normally, when we talk about the pathologies, the origin of the pathologies is of oxidative stress. I mean, the factors could be many factors, biotic, abiotic factors, accumulation of these factors. But finally, that creates an important stress in the cells, independently the name of the organ, independently the name of the system. But when we have metabolic disorder, all these related systems, cells, create oxidative stress, and this oxidative stress and overproduction of oxidative reactive species, which are highly damaging, are accumulated in the cells. And one of the first mechanism of Diasulin is neutralize all these toxic compounds or oxidative reactive species and reduce the damages in the cells. So the first activation of the response of the organs starts there, cell by cell. That's why when we have the resistance to insulin, it is also related to the function of all these organs. And thanks to this blocks of the resistance to insulin, which is related to stimulation of all the secretion of different organs, in the same orchestration starts in neutralization of all these toxic compounds or oxidative reactive species or free radicals, we can call them, which in the cells is causing this to this resistance. So that's why we have in the first time of use of this product, we can observe better analytical results in the laboratory.
Okay.
And is there any different effect that is the
Okay, please.
Diasulin on lean versus obese patients? Is there any versus obese patient?
Obesity.
Lean versus obesity, any different effect of Diasulin treatment? lean patient versus obese patient. Any different effect of Diasulin treatment?
Yes, I mean, we have also in the product some sacient effects. That's why, I mean, together with another product that we have, which is OVEX, which is especially for obesity people, but the mechanisms also are very similar, related with this kidney, intestinal tract, and pancreas and liver. So in combination with this OVEX or alone, Diasulin will also create an important regulation in obese people.
Okay, thank you.
Okay, thank you. Professor Bulan, I have a question. The study from Professor Budi Weweko said there's an Indonesian population, there are 4 subtypes of PCOS patient. How about the use of Diasulin? What do you think? Can we use to do all the phenotype, or we must make a study to know what's the best for the Diasulin?
Well, actually, Diasulin is non-specific for the disorders. Of course, we can have always studies. We are open to make studies. Always we are open. We can potentiate and see, confirm these results. Due to our experiences in different continents, we are actually in 140 countries using this product, and it is non-specific, and the type of the disorder doesn't matter that we may have, but for the confirmation, we are open for any clinical trials.
Okay, thank you, Prof. Bulan. Masih ada pertanyaan untuk Prof. Budi Weko yang di kolom chat ini, kolom Q&A?
Ya, ada satu ini dari Dr. Wayan Kusumedana. Ya, terkait dengan treatment AUB, saya kira treatment AUB sama persis dengan yang lainnya, AUBO ya, PUAO, AUB karena ovulatory dysfunction, ya kita tentu stop bleeding, ya kemudian memperbaiki penyebabnya apa, ya treat the etiology PCOS-nya. Kemudian juga yang paling penting kita melakukan transformasi endometrium ya dengan dosis progestin yang tepat. Kemudian untuk terapi anti androgen, saya kira sampai saat ini kalau kita melihat ya terapi anti androgen itu pada pasien PCOS sangat-sangat selektif ya. Hanya pada pasien-pasien PCOS dengan hiperandrogen yang memang menimbulkan gejala hiperandrogen yang sangat kuat ya. Virilisasi, hirsutisme berat, ya itu mungkin kita pertimbangkan untuk memberikan anti androgen seperti spironolactone ya. Jadi kalau yang lain-lain biasanya cukup ya dengan pemberian OCP ataupun kita memperbaiki ya dengan pemberian insulin sensitizer, androgennya akan turun dan manifestasi klinisnya akan membaik. Kemudian kalau kasus PCOS dengan euandrogenik ya tentunya tidak perlu pasti pemberian anti androgen. Insulin sensitizer ya kalau pada studi kami memang tetap membuktikan bahwa insulin sensitizer itu secara tidak langsung bisa menekan atau menurunkan hormon AMH yang nantinya akan memperbaiki performance ovulasi dari pasien. Demikian Prof. Hendi, terima kasih.
Okay, thank you, Prof. Pco. I think it's all the question is answered. Okay, thank you very much for the discussion. Thank you, Prof. Bulan, and thank you, Prof. Budi Weweko, and also for the audience for the nice, interesting discussion. I give back the time to the Pak Jati. Silakan Pak Jati.
Ya, terima kasih Prof. Hendi. Mohon maaf Prof, apakah sudah ada nama pemenang door prize? Boleh dibantu dipilih?
Ya, ini tadi yang terakhir tadi Dokter dari pertanyaan AUP tadi, Wayan Kusumadana.
Dr. Wayan.
Ya,
kita ada 3 door prize, maaf Prof. Mungkin 3 nama.
Ada usulan Pak Prof. Budi, ini dari Dr. Inu mungkin bisa dimasukkan ya pertanyaannya.
Dr. Inu, satu lagi Dr. Dodi.
Dr. Inu ya.
Dodi Hendradi.
Dr. Dodi.
Ya.
Oke. Bu Desi tolong dicatat ya. 1 Dr. Wayan, 2 Dr. Inu, 3 Dr. Dedi. Sambil saya coba.
Dodi Hendradi.
Dodi Hendradi. Oke. So once again, thank you for Prof. Hendi, Prof. Budi, and Prof. Bulan for sharing with us today the valuable knowledge. Very interesting presentation. Also, Sintesa Health as a marketing partner of Catalysis Spain, we really appreciate to Perfitri for this collaboration webinar. Hopefully, the Diasulin can be one of adjuvant therapeutic option in Pcos management. So, Mbak Desi bisa share door prize-nya dulu before we go to the photo session. Nama pemenangnya? Ya, berikut untuk the door prize winner for today. Ada Dr. Wayan Kusumadana memenangkan Xiaomi Air Purifier, lalu ada Dr. Dodi untuk Travel Air Purifier, dan pemenang ketiga ada Dr. Inu untuk Mocha Smart Tumbler. Nanti akan dihubungi oleh panitia untuk pengiriman hadiahnya, akan langsung dikirimkan oleh panitia ke alamat dokter masing-masing. So before I close this webinar, Pak Didik boleh ini Pak Didik dibantu photo session?
Ya, baik.
Mr. Esteban, please show your camera. Hola. Pak Lanang. Pak Lanang. Bu Nur. Bu Nur. Oke, Pak Didik dihitung aja, nggak apa-apa, langsung aja.
Baik, kita akan, Bu Nur sudah bergabung. Baik, saya tambahkan. Baik, saya akan hitung dalam hitungan ketiga. I will count until 3. 1, 2, 3. Baik, mohon untuk kita terlebih dahulu. Kita akan memasuki sesi foto bersama yang kedua. Boleh barangkali jempolnya diangkat ke atas, Dokter, Prof, Ajati, times up. Ya, saya akan hitung kembali ya, Dok, dan juga Prof dalam hitungan ketiga. Mohon untuk bersiap. 1, 2, 3. Baik, terima kasih. Saya kembalikan ke Pak Jati. Pak Jati, silakan.
Okay. So once again, thank you for our participant, speaker, and all my friend from Spain. See you in the next webinar. See ya. Bye-bye.
Terima kasih.
Terima kasih.
Terima kasih, Prof. Hendy, Prof. Budi.
Thank you, Prof. Bulen. Prof. Iko, thank you. Prof. Hendy, thank you. Mr. Esteban, thank you.
Pamit ya.
Prof. Bulen, thank you, Prof. Bulen. Thank you so much.
Bye. See you later.
Thank you. Thank you. See you.